Hi, this is Dr. Grove Higgins down in Colorado Springs with Neuroathlete Clinic. And this is Pat Marquez, who you'll be hearing a bunch from today, and we'll be doing demonstrations down here.
Hello guys, this is Dr. Matthew Heisey from the Centeno Schultz Clinic. Let me start my video. There you go. We're here in Broomfield, Colorado, and I'm at my Lone Tree, Colorado office. So we're going to kind of go over a few things today to discuss how we can help our patients during the coronavirus, the pandemic. So we're going to kind of talk about a few things. I'm just going to share my screen here. Okay, so I think everybody can see my screen at this point, and we'll go ahead and start that slideshow. So what we're here to talk about today, myself and Dr. Higgins, is kind of step 2, follow-up number 2 on what we're going to be recommending to help folks at home with acute pain, chronic pain. How do we plan for procedures? How do we do therapy exercises post-procedures? And all of those things. So we're going to do just kind of a brief bio of myself and Dr. Higgins, and then kind of briefly go over again what telemedicine and telehealth are, how you have access to your providers, a little bit about, again, what we're able to offer in office as physicians, a little bit about the COVID-19 update, some links, some self-assessment examinations, home relief exercises, resources for pain relief, and then we like to extend the courtesy 10-minute telehealth consults for all new patients if they would like to speak with myself or Dr. Higgins. This is just a little bit about me. I'm a board certified and fellowship trained physician, and I currently practice interventional spine and pain and orthopedics, so ultrasound and x-ray guided injections, sports medicine, physical medicine, rehabilitation. In my practice, in our group, we have published a lot of research papers, and this is the link, as well as centenoschultz.com or regenix.com. I have 2 little kids at home, and then we also practice, again, at Broomfield, the North Denver location, as well as Lone Tree, South Denver location. So I'm just going to kind of end my screen share for a second, and then Dr. Higgins and your team, if you could please, again, introduce yourselves.
Sure, just briefly, I'm Dr. Grove Higgins. I've been 20 plus years in the field of rehabilitation, chiropractor only for the last 15 of those. We do primarily rehabilitation and rebuilding of individuals after issues that like Dr. Heisey helps individuals with. Pat Marquez and I had a nonprofit working with wounded eligible soldiers, which was completely hands-off and was doing things like what we do with individuals online currently, helping them learn how to manage pain, how to rehab things on their own, and learn the tools of that. So this is a space that we're very familiar with. We've helped people from all the way from, of course, the regional area to people all over the United States. We have a current patient in Sweden, and we've even worked with people on the side of Mount Everest at 1,800 feet. Like Dr. Heisey, married, have a few kids that are at home that thankfully we were already homeschooling, so this is old hat for us right now. So take it too much longer and we might go stir crazy too. We'll see. And then Pat Marquez, Coach Pat Marquez here, who is retired Army and has been doing corrective exercise now since 2011. Yes. Yeah. So, and you'll be hearing from him more here shortly.
Thank you, guys. Well, it looks like we are having some more folks, I think, sign on at this point. So I'll kind of take over the screen share for just a little bit. So right now, given the shelter-in-place orders, this is specifically Colorado, we're still able to, again, offer in-office appointments. Oh, sorry about that, guys. Okay, so in-office appointments, and we're still able to do pain medicine injections, pain management procedures, and regenerative medicine injections. So we kind of term regenerative medicine the blood PRP. Right now, we're still underneath kind of the governor's orders. And so what we're able to do is also then have the telemedicine path, and that's both new patients and follow-ups. And so if we are in pain or if we have rehab questions or acute injuries, we want to make sure that everybody is accessible to you as our patient or prospective patient. We also have a little bit more information kind of unfolding today about the coronavirus, as well as some updates on what we can do for in-office, and we'll cover that shortly. We're going to kind of dive into the telemedicine and telehealth. So when we look at the past of a one-on-one physician, patient relationship and chiropractor physical therapy, there was a lot that was hands-on, face-to-face. And because of this current pandemic, what we can do now are both new patient evals and follow-ups via telehealth and telemedicine. So those are the same terminology. Telehealth, telemedicine means that with a video or a phone call, so Zoom, today we're on video conferencing, you can see your provider. And the way that we have it set up in our practice is we have a self-exam video, as well as a questionnaire for the patients to fill out if they're new patients. And we can actually provide these services to all 50 states. We also are able to bill insurance for all of these telehealth or telemedicine visits. And so we found that when we're engaging patients back and forth and having them do the video conferencing exercises and giving us the self-assessment exam, we understand just a little bit more about their problem, as well as the patients understand a little bit more about that problem. We're also able to perform remote MRI reviews, right? So we can upload imaging. We can review other diagnostic data from other tests, EMG tests, x-rays, notes from other providers. So all that can be provided. And just like how I'm sharing my PowerPoint now, we can share the MRI, and we can look at his neck MRI, his shoulder MRI, the x-ray of his thumb for thumb arthritis, have patients talk about their carpal tunnel, etc. So all that's going to be available for both Dr. Higgins as well as myself and all of my partners via telehealth. One other unique thing that we do at Regenix and Centennial Schultz Clinic is our approach to the pain, as well as Dr. Higgins. So we like to think of it kind of this four-pronged approach on the corners of the wall of the house, or the four corners of the property. What's the most important thing of the body? So are the joints stable with the ligaments and tendons? Are the cushion of the joint or the spine, the discs, the meniscus, the labrum, the cushion, the shocks, articulation, diseased, pathological, or overwhelmed or overloaded because of stability or symmetry? And then really a large part of pain and kind of where the body is being controlled from is the neuromuscular system. So how do we control the brain, spinal cord, nerve, muscle system? And we're going to kind of dive into some self-home exercises. I think nerve glides, okay, desensitization techniques are going to be good for that. So we'll have that live video here shortly. Some of our patients have asked us, well, how can we diagnose these things? Well, we're able to, again, have that video conference on Zoom and or the phone call. And then we would like, our patients to kind of tell us a little bit on the history form, as well as do some of those self-exam videos. And at that point, we're still able to do medication management, order new tests, see you in the office, all those things. We're just going to show that video of the carpal tunnel ultrasound nerve. So I actually have one of our providers, and their hand is going numb. He's a physician, and he asked me to do this procedure on him this week because he's having difficulty with his hand right now, providing care for the patients. So we're able to perform those types of ultrasound procedures still in office. I'm going to skip this slide for 1 second. Right now at our practice, what we have is what's called a maximum protection zone at the Centennial Schultz Clinic. And what that means is that we have implemented face mask usage and gloves with all patient and provider contacts in both offices. We have the HEPA air filtration UV light virus deactivation in the rooms. We also have ordered and will be receiving either today or tomorrow actual COVID-19 test kits. Okay, so this is different than if you go to the hospital. What this test kit tells us is, number one, do you have an IgM antibody acute infection? Those are acute. Okay, so if that's the case, then we're going to manage the patients, get in contact with your primary care provider, send you home to quarantine for 2 weeks. The second result will be a IgG antibody showing that you were infected, days to weeks ago, and you're actually recovering. So this is kind of like a golden ticket. This means that you are recovered from the acute infection. You actually have antibodies that are present. And we don't fully understand if you can donate blood. We don't fully understand if you can donate your plasma. We're still kind of waiting on some guidance on what that means if you have this golden ticket. So we're able to provide those tests for our patients that come into the office for procedures. And the way we kind of set that up is one patient at a time come in. You'll be in your car, what we call a virtual waiting room. And then on the way in, we kind of go through everything, what we need to do on your tests and washing your hands, giving you the mask, and then you'll enter the office to meet with the physician. So that's what we are doing to provide maximum protection against viral transmission, but still allow our office to be open to take care of our patients. So then going backwards one step. So this is just kind of the general overview. It's common sense. If you have symptoms, if you are symptomatic, we do want you to stay home. And that's where the telehealth comes into play. The CDC did kind of update their guidelines, right? The obvious things are don't touch your face. We don't want to put anything in the mucous membranes. And we want to make sure we wash our hands for 20 seconds, okay? And this is soap and water. A hand sanitizer, just one little drop and then a quick is not going to do it. We need to be 70% alcohol or stronger, and we still need to have that 20 seconds on the hands when we have that strong alcohol. They updated their guidelines from the CDC that, yes, we do recommend a type of face cover when you're out in public. Face mask or bandanas. In Colorado, we might even have some ski equipment and ski masks that haven't been used much this year. And so if we think about if we go to the grocery store and things like that, that's probably where most people are going. And so we still want to protect ourselves and maintain social distancing and provide a face mask or bandana when we do go out in public, okay? In our offices, we do have masks for patients. Some internal data from the Department of Health as well as the Johns Hopkins is showing us that we're going to have the peak virus load and hospital admissions between April 17th and April 24th. Some are 17th to 20th, some are 20th to 24th. So I kind of grouped them in here into a nice 7-day window. So the governor extended our, stay-at-home order in Colorado. So we're going to, I think, see this peak in another 2 weeks. Basic mild symptoms, we want to stay home and call our regular doctor, okay? And that's just, a little bit of cough, low-grade fever under 101, abdominal pain, mild shortness of breath. Stay home, let's call your primary care provider. You also want to quarantine from other patients or other family members in your house, okay? If we have more symptoms, kind of moderate symptoms, shortness of breath, chest pain, we're having trouble walking into maybe the garage to kitchen to family room or even stairs, those are more moderate symptoms. We absolutely want to call the doctor, and that might warrant a visit to a hospital urgent care for a breathing treatment and or like a COVID test, okay? And then when we have severe symptoms, severe chest pain, severe shortness of breath, stopped breathing, anything like that, we're still going to be kind of under what we call emergency medical services, EMS, call 911. Anybody that is above the age of 65, immunocompromised, whether you're diabetic, whether you take chronic steroids for autoimmune disease, any organ transplants, asthma, any COPD, if you smoke cigarettes, congestive heart failure, it's going to be safer for all of us, for those folks to stay at home. That's going to decrease your risk of viral transmission and decrease the risk of you being an asymptomatic carrier and giving it to everybody else. So I recommend everybody kind of maintains updates on the cdc.gov website below. Okay, this is kind of the link that we have, so I can email these to all patients individually. And these are going to be those educational links and self-assessment exam videos and some of that range of motion that you can do at home. So once you're interested and or if you email us, my team, or Dr. Higgins, I can send our patients these links. We'll put this slide up at the end as well. This is going to be our contact information. Also, in addition, we do have the Broomfield office location, Broomfield, Colorado by Boulder. And then Dr. Higgins has a fantastic facility basically halfway between me and Colorado Springs in Monument, Colorado. So we're kind of centered everywhere, north of Denver, south of Denver, and then close to Colorado Springs for all of our patients. So that's kind of the overview of what telehealth, telemedicine is, what we're able to offer via telehealth, telemedicine, which is still a comprehensive patient and physician doctor evaluation, medication management. We're still able to do some procedures in office, and we have our plan, what we call the COVID maximal protection zone here. And that's going to allow us to test our patients that are undergoing procedures, as well as testing all of the providers, all of the physicians in office, so we can continue to provide care for all of our patients. So with that, I'm going to kind of turn it over to Dr. Higgins, and then we'll be back for some more fun exercises here shortly.
Fantastic. Thank you very much, Dr. Heisey. So let me switch over mine. All right. So where we left off last week, we were discussing where pain came from and how you can get a handle on it. There are some poll questions that Amelia is going to pop up for you, and if you would be so kind as to answer them when they come up. So this first one was, where were you on the webinar last week? And if you can answer that, that'd be great, just so you know who we're talking to. And then we'll be looking at other areas such as, where's most of your pain, things like that. So that way we can speak directly to it. We will get into some nerve glides here, but we want to get on the issue of pain just a little bit more, because what we've found working with patients all over the world, especially some of the veterans that we've worked with, is understanding what pain really is and what it isn't. Goes a long way to helping people start to manage their pain. All right. So this is where I'm going to invite Pat Marquez to come in and dive a little bit deeper.
Hello, everyone. What we're going to do first is kind of talk through 5 key concepts about pain. And then we'll go into chronic pain a little bit and explain, make sure everybody understands the difference between acute pain and chronic pain. But these 5 key concepts are things we always talk with all of our clients, so that they understand what pain is, because it is, when you're in pain, it's hard to conceptualize sometimes, because you're feeling it at the spot that you feel it, right? So key concept number 1 is that pain is 100% of the time an output of the brain. So it doesn't mean that the tissues and in your arms, legs, or in your joints, the receptors and things like that aren't involved, but it does mean that the concept of pain, right, or the actual pain that you feel, is a danger signal from the brain to you that something is going wrong. So this is kind of shows what we used to think about pain, right? So the little diagram there comes from like the 1800s, where the guy actually put his toe in the fire, and we think that a pain signal is sent to the brain, but that is not at all what actually happens. The real aspect of what happens is that a danger or a threat signal comes from that noxious stimulus. You can kind of see that by the little fire there. And that signal travels up through peripheral nerves, through the spinal cord, and to the brain. And then the brain is evaluating how dangerous that signal is. And if it is dangerous, if it thinks it is a threat to the system, it's going to send pain down to that area so that you pay attention. A good example is if I had a pen or a toothpick or something like that, and I gently pushed it into the skin, that is a noxious signal, but it's not a strong one. If I were to continually to push harder and harder and harder, eventually that signal is going to raise up high enough in which the brain's going to send a pain signal. So the big key point here, number 1, though, is to understand that pain is an output. It is not an input to your brain. Threat inputs come in, and a pain output comes out from your brain, so that you can address whatever is going on, right? And pain is, it's what it keeps us alive, right? It's we touch the hot stove once, we generally don't do it again, right? So it's very important from a survival standpoint for the organism, or us. Second key point here is that, so this person, when I kind of flew into that as I got going on the previous one there, that the pain being a construct made from the brain, if that's the case, which it is, then if we target the brain, the nervous system for in training for people who are experiencing pain, we can make a change. So we talked about this last week for those of you who were on last week. This is what's going on all the time in our bodies. We're constantly receiving sensory input. Three big types of sensory input are external, and if you think about that as your five senses, right? That is our sensory input that tells us what is going on in the external environment. Secondly, we have internal sensory input. So things like your gut health, your breathing in your lungs, right? Your vestibular system plays into this too, which is your inner ear, which orients us towards gravity, and it gives us the sense of which way is up, right, and which way we're going. Inflammation that we have in the body would be another, sensory kind of input that comes to the brain.
Which is what the PRP and the stem cells help to mitigate immediately, and you get the quickest results from pain relief wise, as it helps to reduce that inflammation locally and reduce that irritation globally.
Yeah, so it's changing that sensory, that internal aspect of sensory input, and then the brain feels less threatened. So the third we wrote there is proprioception, big long word. Basically, it's your brain's 3D map of you in time and space. So proprioception is a sense you have that of where your joints are. So even when my eyes close, I know my arm is straight. Now it's bent to 90 degrees. Now it's straight again. And that seems like a very simple thing, but when we have poor proprioceptive input, especially around joints, and the nerve endings that sense this input are in the muscles, tendons, and joints, and if we have a problem in that area, then it sends basically either a threatening signal or just a weak signal to the brain, and the brain does not see that area well. Think of proprioception as your brain's 3D map of you in time and space for movement. So all the sensory input is coming to your brain. Your brain has to interpret and decide what it thinks about all this input. And this is obviously happening in a very fast rate. But every time when you're getting sensory input, if you go to do a lunge or a squat down to pick something up, your brain is comparing all previous times it has done that with what's going on now, trying to decide if this is threatening or not. So once the brain makes a determination of that sensory input, interprets all that different sensory input, and makes a decision, it's going to produce an output. So when we talk about outputs, we're talking about whether, first and foremost for this discussion, is pain or no pain. Now, other outputs include things like, are you very stiff? Or on the flip side, are you very flexible? Do you have weakness in a certain area or certain muscle, or is the muscle strong? As well as movement quality. How well do you move, or how coordinated you are, either poor or good coordinated movement is a output from the brain. And then what often happens then, if we start to move less, this kind of is resulting in this of the chronic pain cycle, if you will. We hurt something, we move less, it starts to hurt. We move even less, it hurts more, right? So movement and how well that movement is executed is an output from the brain. And that output then goes in the cycle and affects the input. Because if I'm moving less, if I'm moving that joint less, now I continue to get less signal to the brain, and the brain doesn't understand that area very well, doesn't see it very well, and that is threatening to the brain. Go to the third key concept here. This is really important to understand too, that injury does not necessarily equal pain, and having pain does not necessarily equal having an injury. Seems strange, but when we have objective evidence of tissue damage, it doesn't always mean it's the cause of pain. I'm going to show a little picture here that's taken from a study, I think it was in 2014 or 15. This was of somewhere around 3,100 asymptomatic folks, meaning they had no pain. So you can see there that 80%, so these were MRIs done on the spine. 80% of 50-year-olds had disc degeneration, but they had no pain, right? 60% of those 50-year-olds had disc bulges, but they had no pain. So we all have broken things in our body that we don't even know about. And there is a huge amount of other studies that show things like, I've even seen some that say that 80% of people who have no pain in their knees are walking around with some kind of meniscus tear. So we can have injuries without actually having pain. And the flip side is also true. So we can understanding that pain is a threat or an action signal from the brain, right? And not an indicator of damage. And how do we know this? How can we have pain without an injury? And we'll talk about the healing process a little bit. But we know this through phantom limb pain. So as an example, when Dr. Higgins mentioned that we worked with a lot of wounded warriors out of Fort Carson here in Colorado Springs a few years ago. And I was fortunate enough to be a support guy for one of our soldiers who was a double above knee amputee. In fact, he had like nothing on one side and about a 4-inch nub of leg left on the other side. But the guy was an awesome athlete, and he did mono X skiing. So that's when you're in a seat, we have one ski and you kind of have outrigger pole skis. And he competed in the X Games in the mono X. And we would go up skiing to train, and I would be there to help him get around and things like that. And I can remember being on the chairlift with him, and all of a sudden he yells out in pain. I'm like, dude, what's wrong? And he's like, my toes are killing me today. Now his toes were long since dusted in Iraq years ago. All the tissue had healed, right? So all that was over, but he was still got pain. That's what phantom limb pain is. And there's a lot of different explanations for that. But you have to understand that pain does not always mean that you have something that's currently damaged. And if you do have something damaged, it doesn't necessarily mean that you'll be in pain. This is another proof, if you will, that pain is 100% a brain construct. Okay, key point number 4, pain is individual. So there are a lot of areas in the brain that light up, if you will, when you have pain. And if we do a functional MRI, we'll see that a lot of similar areas light up, but they light up differently for different people. Just a quick kind of picture, and we're not going to go into a big neurology lesson here. I'm not going to talk about each of these areas, but these are typical areas that light up on a functional MRI when someone experiences pain. Now, you and I could both have knee pain. It could be in the same exact spot on the outside of our knee. It could hurt at the same point when we bend the knee right to 90 degrees. Everything is exactly the same. But if we both had functional MRIs on, when we move into that range of motion, it hurts. These different areas will light up at different levels for both of us. Pain is very individual. That means you need a unique solution to your pain, which is what we try to do with everything. We'll be talking about this a little bit more when we get into the practical things. So lastly, you can get really good at being in pain. It's important to understand that pain is a skill, just like anything else is a skill. And that doesn't mean it's one we want, but it does mean that you can get good at being in pain. So this is why we don't like the term no pain, no gain. We like the term no pain, all gain. So if I exercise, and whenever I'm doing a shoulder press, and right when I get to about here, I get pain in the shoulder, and I just keep pushing through, right? And I just keep pushing through. I am literally training my brain that right here it hurts every time. And so we have to make a change in what you're doing in order to not make pain a skill and not get good at being in pain.
And real quickly on my side, just to add to that, is that the longer you're in pain, so chronic pain patients, which are pretty much everyone that's on this webinar, if you have any kind of pain past 3 months, it becomes hardwired in. So you saw that diagram that Pat showed before, where all the areas of the brain that are involved, it can be somewhat hardwired. So even after treatment that is very palliative, sometimes we can have prolonged pain because the brain needs to pair those connections back and basically rewire before you start to get a resolution of pain. However, you can change that wiring right now, which is what we're going to be getting into.
So I just wanted to put this slide up here. So when you'll have access, of course, to watch the webinar again later. And we just want to put everything on one slide there so you could kind of see it. An important point to make here, though, is yes, pain is a brain construct. It doesn't mean it's all in your head, right? Or it's a psychological thing. It is a physiological thing that is going on. And but it makes it easier for us and easier for people who are in pain to understand what's going on if you understand these 5 concepts, and then we can utilize therapies in a lot different ways that are that can be more and more helpful, so that the threat is not as important to your brain or as worrisome.
So quick poll question that will pop up. What areas of the body do you feel pain in most? Just so that way we can speak to that. We're going to get into some practical application of this real quick, and then some practical tools for you to start using right now. So if you can answer, where do you feel the most pain, so that way we can target this specifically to you today. And then next week we're going to be getting into some very specific areas in the body. All right. So if everybody's submitted the best that they can, we should be able to start seeing some results here.
We should have one more slide.
Okay.
So we get time to get the results.
Okay.
There we go.
All right. So while you're answering that, there you go.
Okay. All right. So while those are getting answered, we're kind of collecting that so we know which way to go with the practical stuff. I'm going to talk quick about acute versus chronic pain. So acute pain is a pain directly related to an injury that just happened. So I roll my ankle, right? I get a paper cut. Whatever has happened, where that injury happened, right? The nerve endings that sense threats, sense that something is wrong or out of homeostasis, are sending that signal to the brain. The brain is processing that, interpreting it as threatening, and sending pain there. Now, the key part about acute pain is that pain goes down as the tissue heals. That's what we should feel, right? Sprain our ankle, and then 57% low back, okay, and SI joints. All right, so we'll use that as an initial basis there. But acute pain should recede as tissue heals. So when we have chronic pain, though, that's pain that continues on long after tissues is healed. And then, tissues heal at varying rates depending on the injury and what happened and what tissue it is and things like that. But usually in weeks to months, tissue is healed. So why does pain persist? If you have chronic pain, why does that happen after tissue is healed? So if you look at this little chart here, we talk about, I'm trying to get the slides.
It's because of the poll. There you go.
The poll. All right. So we talk about not a pain threshold, but having a threat threshold. So under normal conditions, you have this higher level threat threshold that when you have a threatening event, that it takes a larger amount of threat before the brain decides to send pain. But when you are in a chronic pain state, what has happened is your threat threshold has lowered significantly in your nervous system. And so now, a threatening event has a very small amount of threat before the brain sees that as threatening to the organism and sends pain. So basically your brain's threshold, right? The threshold of your reaction to threat has lowered significantly. And another way to say that is when you have chronic pain, you have a hypersensitive nervous system. It doesn't mean that we can't change that. We most certainly can. But it is important to understand that after tissue is healed, when you still have pain, a large part of that is because of the threat that the nervous system still is receiving.
I just want to add in and kind of chime in for everybody. So it's very important that we as humans understand this input output of fuse box breakers, as I tell my patients, and how we affect change. And that's why also we're testing light touch, vibration touch, sharp touch on your feet and your hands when you have back pain or neck pain. Why? Because again, those are those outputs that go all the way down to your legs. So this is really important, and I hope everybody stays engaged. And then once we understand a little bit about this, that's how we use all of the tools in our toolbox, whether it's the therapy, the exercises, the hands-on, the muscle activation, injections, procedures, medications, to re-change kind of this feedback loop or this cycle of the brain, spinal cord, and then soft tissues. So it's really important that we kind of understand that from this 30,000 foot overview, and then we can dive into some more perhaps low back SI joint exercises and cover that, since that seems to be the #1 area for patients right now.
All right. Okay, so yep, we're heading into that. So you guys saw this before here. So we're going to get into that later here. Sorry, a little dialog box popped up, so it prevents moving here. So we're going to do a quick assessment. So that way, as we move forward with these nerve glides to help you with that low back pain, we're going to look at how do we change these inputs, but how do you know that anything has changed? Because again, your pain might not change, but the range of motion might. Or your range of motion might change, but the pain will happen someplace else in the range of motion and such like that. So just quickly on this page here, you're going to be looking at defining your pain-free range of motion here in just a moment, and Pat's going to help you figure that out, and we're going to focus it down to the lumbar spine area and how you can do that assessment well. And then we're going to do something to change the input, and then we'll reassess it. And then when we do that drill, we'll do a poll just to see if it's changed you. Now, some people, after doing this, you might get a change in the positive direction, an increase in range of motion, or an increase in pain, or a decrease in pain, excuse me. But some of you might do something that's very palliative and simple looking that we're going to show you, and you might get an increase or a decrease in range of motion or increase in pain. We want to know that. It doesn't mean that that's a bad thing. It just means that we need to change it and individualize it for you. And not all tools are going to work for all people, even if it's seemingly good. So I'm going to stop sharing my screen for the moment. And we're going to switch over to our other camera, which has got Pat on it. So, okay. So since we're looking at mostly low back pain, the good place to do an assessment right here is just range of motion and pain. Why don't you coach them through, and I'll do the ranges of motion, Pat. Yeah, let's do rotation first.
So for low back pain, a good range of motion assessment would initially be some rotational range. So from a seated position, Doc is going to just try to rotate his torso, and the seated position is good because then your hips won't move. First, we'll just rotate to the right, and then we'll rotate to the left. And so he's not going into pain. Right? So if you have pain right now, be careful that you are assessing your pain-free range of motion. So move slowly and just go to a spot that is as far as you can get without pain. And this is your initial assessment. We want to assess and reassess everything we do because we talk about pain being individual. So that means we need to be sure that the drills we're trying are positive for you, right? So once you have your pain-free range of motion assessment, then we can try some different things to see if we can improve that range. So one thing we could do is get good reps in a pain-free range of motion, and then see if that changes your end range of motion. So for Doc, as an example, if he were to rotate to the right and to the left within his pain-free range of motion gently, then we're going to do, and let's keep doing a few more reps. Right? Staying within pain-free range of motion, then we can retest then after that and to see if just getting good reps in that are pain-free in that range actually improves your end range. You get farther without going into pain. So he would then reassess. So another aspect you could do is see if how the speed at which you do in motion changes how far you can get or how much pain happens. So let's say that Doc had some pain when he moved to when he rotates to the right. He could also try slowing this down and going super slow throughout the entire range of motion and seeing if he actually can get farther by moving slowly through the entire process. Because the speed at which you move, consider that like load, like putting weights on a barbell. That makes things more threatening, just like more weight on a barbell does. So you want to reassess?
Yep, and I actually improved just by going slower. I don't have any active injuries or pain or anything, but just by going slower, in that last example, I was able to go farther without feeling the same tension versus when I went my normal speed before. So that was a positive output for me. So if you tried that, please give feedback on the poll for a moment and try the different speed and see if you get a different output. Did it increase your range of motion? Did it decrease your pain? Or did it do the opposite just by changing the speed?
And another thing that we are careful to discuss with our clients is that if we try something and then we reassess you and things get worse, we're not worried about that because it's data. Then now we know what is more threatening to your brain. So it gives us more data on what we can do. Right? Did you want to do a different assessment now for a little bit?
You can do a toe touch right from the seated position.
Okay. So from the seated position, Doc's now going to do a toe touch as like a range of motion assessment, but also a pain assessment on how far can he go before getting a pain. Obviously, you could do the standing too. It would depend on your level of issue and things like that. It would be very specific to the client. This is a safer means of doing that. Let's see how much forward flexion he can get before going into.
You could either do it with your feet together or feet apart. I chose to do it with my feet apart and just to slump forward and like I'm going to touch the toes, my toes, excuse me, and then I touched my ankles just to give myself a sense of how far I went. So then we can change the input again.
Statics or what?
Sure. So here's where we're going to do the first of nerve glides with you. And so if you have back pain, oftentimes by getting the dynamics, the movement of the nerve, in this case we're going to go aiming for the sciatic nerve and we're going to go for one of the distributions, can oftentimes relieve quite a bit of back pain here. So Pat's going to walk you through me how to perform this. So if you find a chair or something that you can sit on the edge of that of course won't roll on you, then we'll get an idea of how to do this the best.
Okay, so if we were going to do this nerve glide on the right leg, from this position, Doc would extend his right leg and have his heel round and round. So he's keeping the knee locked out. It doesn't have to be a hard lock where you feel your quadricep firing like crazy, but the knee is staying extended. From this point, he's going to take his leg and bring it in towards the center line slightly.
Wait, it's across the middle of my body.
And then he's going to gently internally rotate the leg. Now from this position, he's pulling his toes back to his shins, and then what's called inverting the foot, or turning his foot in like he's trying to put the bottom of his foot to his left. Holding this position, he's going to start off with a long spine, and he's just going to hinge forward. So he feels some tension. He's going to tuck the chin and round the upper back slightly. You have tension there? So once you've gained some tension, you can use a term we call flossing the nerve by gently unlocking his knee and locking it again. And so we've tensioned this whole sciatic nerve line actually all the way down towards the foot. And then we're releasing that tension slightly by unlocking the knee and then tensioning again. We call this flossing the nerve. And a couple points here. One, it should not be painful. It may feel like an extreme stretch, but it shouldn't be painful. Two, you only need to do really 6 to 8 of those repetitions. And now we would reassess.
And that gives me actually a fantastic range of motion increase just doing one leg pain-free.
Sorry about that.
And that, again, increases my range of motion and made that feel very, very easy. So reassess that drill as well. Amelia's already popped it up. And mark whether it improved your range of motion or not, or your pain or experience of pain. Okay, and we'll go on to a variation on this. So the and you may be starting in this position in order to do the nerve glide, and that is perfectly fine. Wherever you find the benefit, and you may only need to put your head down, and that's fine. Try to approximate this as best as you can, and we'll post this as well. So now we're going to do another division of the same nerve. So we're going to start off the exact same place, and then Pat will walk us through how to change it.
Okay, so Doc's leg is extended. It's across his center line, and then it's internally rotated. He's pulling his toes back to his shins again, but this time, instead of turning the foot in, he's going to turn the foot outward. So sometimes this can be hard for people to keep that outward turn of the foot while keeping the knee lock and the leg straight. But this does a different branch, and it could affect you differently. From there, the spinal positions are the same. He hinges forward until he feels some tension. At that point, he tucks the chin and rounds the upper back. The reason these are affecting the nerve glide is because it's pulling the spinal cord up away, right? So we are stretching that nerve from the spinal cord all the way through down to the lower leg. And then he's going through his flossing again, where he's unlocking and locking the knee. There are some other techniques with nerve glides as well, where you can slide the nerve, and then you can also completely slack the entire nerve. But this is the easiest one to show for people and for people to do at home. After about 6 to 8 repetitions, he would reassess.
Good. All right, and yep, the poll keeps popping up, which is awesome. Thank you, Amelia.
Okay.
Excellent. Okay, and then one more variation before we go to Q&A.
All right, so our third variation off this sciatic nerve glide, again, the same leg position, leg straight. It is brought over across the center line, it's internally rotated. This time with the foot, though, we're going to do a different motion. Doc's actually going to point the foot and then turn the foot inward or to his left with his right leg. And then he's actually going to try to curl his toes. You may feel this all the way down into your arch. Again, it shouldn't be painful. Tension is okay, pain is not. Then he assumes the same spinal positioning. He hinges forward a bit to get some tension. He tucks his chin, rounds his upper back, and you can see he's feeling a different distribution of the nerve glide now. And then you do the same thing by unlocking and locking the knee to floss that nerve. we have nerve glides for different distributions. That was a little out there. Different distributions for peripheral nerve in the lower leg, as well as several for the arms, scapular area, and neck and trapezius area.
And again, these are all individualized. So what worked for me will not necessarily work for you. We may have to tension it differently, but this is where the telehealth component of this is very important, and getting the proper coaching to help you find how to use the tool. This is going to be helpful for just about everybody, but it has to be employed correctly, and it might be one of those tools that gets set to the side before it gets used commonly, before the irritation that you're experiencing will allow it.
So if we just for a second go back and think about, before we go to the Q&A time, that pain is a brain construct, and if we change the input in a positive way, we can change the output of pain, right? Eliminate pain or less pain and that kind of thing. So that is what we're doing with nerve glides. It's basically giving mobility to the spinal cord as well as the longer peripheral nerves, and moving the nerve gently again, right? And changing the input from the nerve itself, actually, in the case of nerve glides, back to the brain, and we can often get some great response from this.
All right.
Okay, everybody. So in summary, we really appreciate spending your lunch hour with us. Luckily, my two kids are sleeping. But what we're going to do is just show you that contact information. And then here I shared my screen. We're going to update Dr. Grove Higgins' email as well, because we have his new facility out in Monument. We have, again, 2 offices for Centennial Schultz Clinic, and then we have Dr. Higgins and his team in Monument, Colorado. And right now, case by case, we're still able to do, again, in-office visits and procedures on certain folks. So we just need to kind of establish that telehealth, provide resources to help everybody along through the next coming weeks. If you have any feedback for us, please let us know, shoot us an email. And I think with that, we'll be kind of off to the races to get ready for next week. Thank you, everybody.
Excellent. Thank you.